of potential infection or potential prostatitis. We may have to do a culture of the urine to make sure that we identify any organisms that may be causing any infection. We would also look for any WBCs in our urinalysis as well. We're also going to evaluate the creatinine and the BUN because that's going to let us know how well our kidneys are functioning. And if these patients are diabetic, then their kidneys may already be compromised. Now, the PSA is done, but that depends on the patient's life expectancies and the circumstances. I think we've talked a little bit about that the other day. So it's a very individual decision. It's usually made between the patient and the physician, and the normal is around 0 to 2.5. Now,
Dr. Buie?
Yes.
Can you remind me what PSA stands for?
Prostate stimulating antigen.
Thank you.
If we are looking at a male that is 70, let's say he's 70, 75 years old, and his PSA may be 5, maybe even up to 6, that doesn't necessarily mean that he has cancer, because the PSAs do increase with age in some people. So basically, if he had one that high, it would just mean that we needed to do further workup on him to make sure that he doesn't have the cancer. Okay, does that make sense? And another level that we would also look for if we were kind of trying to determine if he had cancer or not was the serum acid phosphatase level. That's also going to be elevated with the presence of cancer. So those are the main reasons that we are doing the digital rectal exams and the PSAs. And, a lot of research recently has shown that the PSAs are not that reliable, and some physicians don't even do them anymore. So it's something that's very individual. So I want you to be aware that there is a scale. I do not expect you to know what this scoring what it consists of, other than just the major components of it, because it's not something that you will have to do. I'm not going to ask you this on the test, but I just want you to be aware that there is an International Prostate Symptom Score scale out there. And basically, it just looks at the patient's symptoms and grades them on a Likert scale of 0 to 5. And then depending on what their score is, it determines what the next step needs to be. If it's less than 8, then just yearly evaluations, or if their symptoms increase, they may need more close follow-up. And if it's 8 to 35, then they may want to do some additional testing to determine if there's something else going on. Other tests that we can use is the urinary flow rate. It's the amount and speed of urination. And basically that can be done in a urologist's office. They will usually give the patient a lot of fluid to drink, and then they will have them void, and then they measure the amount and the speed of urination. So that kind of helps them determine if the patient is truly having a problem with hesitancy or not completely emptying their bladder. And then, as like we do in the hospital, sometimes you can do the post-voided residual measurement with your ultrasound. And then if you find that they do have a substantial amount of urine after they have just voided, then that may be an indication that intervention may be necessary. And then there's cystos that we can do as well. transurethral and a rectal ultrasound. I think I showed you that the other day when we were looking at doing the biopsies for cancer with the little probe that they go in rectally and are able to view the tissue in the prostate gland and surrounding the prostate gland. And of course, our bladder ultrasound can always let us know what's going on in the bladder. Is there anything going on there that we need to be concerned about? So how are we going to manage these patients? Well, if they're not having any problems, then there's really no need to treat it. If they're not complaining about it, then we probably won't treat it. If they present complaining about it, then it's bothering them enough that we do need to take issue with it. So that's something that's very individual. Now, some of the treatment option overviews, and these are just overviews because it all depends on the patient and it all depends on the physician. A lot of these patients also have other comorbidities. They have cardiovascular disease, or they have hypertension or diabetes, other things that are going on with them along with this. But usually our first line of treatment is going to be the alpha blockers. And this particular type of medication it helps to relax the prostate muscles. And then it allows the gland to respond to this medication. Flomax is a good example of that. So they relax that smooth muscle in the gland. So when they relax the smooth muscle, that decreases the resistance and improves their urinary output. And it also improves their peripheral vascular flow and resistance as well. So with some of those medications, we do have to be very careful with them because they dilate blood vessels. So what happens to our blood pressure? It drops. So we have to encourage these patients to be very, very careful when these medications are started, so that they get up slowly, they don't make any quick moves, and they allow time for adjustments. They should not stop these medications suddenly. So those are some of the things that increase blood pressure. Like I said, heart rate may go up with some of these medications. They can have syncopal episodes, and they also need to be cautioned about being very, very careful in hot weather, because if they're outside working or they're outside standing for a long time, that in itself is going to vasodilate them. And then in combination with these drugs, it can cause them to have syncopal episodes or dizziness and lightheadedness. So we need to make sure that they know that they need to report any of that, those symptoms. Another thing with Flomax is that the patient needs to make sure, if they're having any type of eye surgery, particularly cataract surgery, that they notify the physician that they are on it, because Flomax is a smooth muscle relaxant, so it's going to affect the pupils. And that can be concerning to the physician if he doesn't know that they are on these medications. He may think that, you know, something has gone wrong when it really hasn't. It's all related to the medication. We've pretty well talked about all of those. Ejaculatory dysfunction is another problem that you will hear some of these patients complain about. And we have to be very careful about the PD5 drugs, which is your Cialis and Viagra, all of those drugs, because they can cause hypotension as well. So you want to make sure that your patient knows that if they're taking the PD5s, that they're waiting at least 4 hours in between the Flomax and the PD5s. Okay. Another group of medications is the 5-alpha reductase inhibitors. And basically what this type of medication does is it decreases the size of the prostate gland, and it helps to prevent the conversion of the testosterone to the DHT. The problem with this is that it takes so long to work. It can take 6 to 12 months before the patient can see any signs or symptoms of improvement. And a lot of times they are going to stop taking it before then because they're not seeing any improvements. So those are some of the problems with that particular medication. So you usually see the Flomax used first of all. And there too, this has a lot of the same problems with the side effects. So we need to be very mindful about that. We also need to be mindful if any pregnant people are handling this medication, that they always wear gloves. Well, we should all wear gloves, but particularly if a pregnant person is handling this medication, because it can cause fetal damage if it's absorbed through their skin.
Dr. Bowie?
Yes.
Do we need to know the particular meds for both classes, or just what they actually do?
No, just the categories. Does that make sense?
Yes, ma'am. Thank you.
Like the alpha receptors and the blockers.
So we just need to know the classification, not the medication name.
Correct. Right.
And is that
just
for all of them?
I'm sorry?
Is that for all of them?
All of
like
what?
all of the BPH meds? Yes.
If you just know, and I did not go into a lengthy presentation of the medicines. I tried to get the ones that you're going to see the most commonly used in the hospital or in this clinical setting, because there's combinations that can be used. But the main thing that I want you to get is what each category has as far as side effects, each classification. So that was the main thing that I wanted you to get from that. Okay, and with the 5-alpha reductase inhibitors, we can have reduced ejaculation. They can have sexual dysfunction, infertility. So this may be a problem if the guy maybe is in his 40s or maybe even his 50s, and he has the prostate problem. He's taking the Avodart, and then let's say that he decides he wants to have more children, then that may be a problem. And it may or may not be reversed by them stopping the medication. Gynecomastia, and you remember what all of that is, and anxiety. And just the whole situation can make them anxious. And we'll talk a little bit more about that too in a few minutes. And then, of course, a decreased PSA may also occur with these medications. Now, your anticholinergics is another classification of medications that are used. It's used more by itself, and it's used to treat the symptoms, those irritating symptoms of the overactive bladder, like having to run to the bathroom every 30 minutes or an hour, or having to go right then and you can't wait, or having problems with incontinence. And ditropan and Detrol are the most common ones. Ditropan is oxybutynin is the most common one that you're going to see used in the hospital setting. Side effects, let me just say that they are very extensive with the anticholinergics. As you know, the primary ones that you're going to have patients complaining about is going to be the dry mouth, blurred vision, tachycardia, and constipation. And then the list goes on and on and on and on and on. But those are the primary ones that you're going to see with patients in the clinical setting. So it's no wonder that they don't take the medication if they have all of those side effects with it. Now I want to talk a little bit about some of the other treatment options that we have available. We have a minimally invasive method, which is a transurethral microwave therapy. And basically what it is that they take a little probe and it is mounted on a urethral catheter, and then it is inserted and it heats and destroys the prostate gland. So the high temperatures are what destroys the gland. It's usually used for moderate to severe symptoms. It is not considered a surgical procedure, so therefore it is a good option for somebody that might not be a surgical candidate. Usually it can be done on an outpatient basis. These patients don't usually stay overnight. There's usually very few sexual side effects as compared to some of the other procedures. And it's usually performed under local anesthetics. They're going to have a catheter too, because when you go in there and you start destroying that prostate tissue, you're going to have swelling in there and inflammation. So they're going to have urinary retention if you don't put the catheter in for a few days after the procedure. Urinary tract infections may also be common with this procedure. And symptoms are very slow to improve with this particular type of procedure. It's just because we go in and destroy that tissue, the results are not instantaneous. And of course, that tissue can grow back, so they may have to be retreated again somewhere down the road. Okay, the next one that I wanted to mention to you is the interstitial laser coagulation. And basically what it is a laser that is used to vaporize or coagulate away the prostate tissue. It's usually done on an outpatient setting too, and it's usually very effective at providing substantial symptom relief. And the response after this therapy is much quicker than it is with the other one. There's usually very minimal blood loss. Now, one of the problems with this is retrograde ejaculation. So that means that rather than the ejaculatory secretions coming out, they go backwards into the tract. They may have urinary frequency and urgency as a potential side effect. And of course, they may have some blood in their urine, but that's kind of to be expected with something like that. And they too may also have some urinary retention. But the good thing about this particular type of procedure is that they do get pretty quick relief from all those symptoms that have been bothering them for so long. So we just kind of go in there and coagulate that extra tissue.
Ms. Bowie, quick question.
Yes.
Between the laser therapy and then the microwave therapy, the main difference between them two is that the microwave therapy takes longer to see results and you may need retreatment compared to the other one that acts quicker, but will you need retreatment with that one?
Not necessarily. Okay. The research has shown that the chance of and they could have to have a retreatment, but it's not as likely as it is with the burning.
Okay, thank you.
Okay, the next one is it's also a minimally invasive surgical procedure, and basically what it is a very thin, tiny metal band is used to go into the prostate gland, and then it just cuts it out in chunks. The problem with this particular type of surgery is that they have to have either general or spinal anesthesia. So if you have a patient that has a lot of other comorbidities, let's say maybe they're a severe chronic lunger or they have severe heart conditions, general anesthesia might not be an option for them. But spinal might, if they can get it, if they can put it in and it can be effective enough. Typically, these people stay in the hospital 2 or 3 days. It just depends on the individual patient. It does improve their quality of life and it does provide symptom relief. However, it does not come along complication-free, unfortunately. And this is actually the gold standard for treatment. And the problems that they usually have with this particular type of procedure is they either have urinary retention or they may have some incontinence after the procedure. And then we're going to talk about the TUR syndrome too in just a few minutes. Contractures in the urinary tract, the strictures, and then contractures of the bladder neck are also things that are seen with this particular type of procedure. And occasionally the patient may have to have some blood transfusions. Typically they don't, but it's certainly something that is not uncommon for these patients. Now, the other thing that I wanted to make sure that I mentioned to you before we move on is, well, let's go to the next slide and then I'll tell you about that. Is the invasive surgery is an open prostatectomy, and it's where they go in through a suprapubic or a retropubic incision in the lower abdominal area, kind of like in the bikini line where ladies have hysterectomies. They go in that area, and then the reason that they do this particular type of procedure is because the gland is too large for them to remove any other way. So the best thing to do is just to go in there and get it and remove it. The side effects with this, of course, is a longer hospital stay. We may increase their risk of developing other complications by having them in the hospital longer. They're more likely to require some blood transfusions. So those are some complications that go along with this. Now, the TUR syndrome is a syndrome that I want to make sure that you know about. You won't see it that often, but I do want to make sure that you know about it. It's typically associated with the TURP. And basically what happens is when the TURP is being done, there's a large amount of solution that's very similar to water that is used for irrigation. And this solution is typically low in sodium. So what happens is the body absorbs a lot of this fluid, causing the overall sodium in the body to drop. Does that make sense? Yes? No?
Yes.
Okay. All right. So basically what happens is the irrigation solution is just absorbed. And, you know, if you've ever taken care of a TURP patient, after surgery, they also continue the bladder irrigations, because if not, and they have bleeding in there, they're going to clot off and they're not going to be able to void. So that's going to be a problem. Now, one other thing that we need to make absolutely sure when we're taking care of these TURP patients that are having bladder irrigations, you want to make sure that they continue to put out urine too. So if you're irrigating the patient with 1,000 cc's of irrigant every hour, then you want to empty that catheter every hour and see how much above 1,000 that you have, and that's going to let you know how much urine they're putting out. And these patients, it's impossible to do like hourly outputs on them, like down to the cc, like 30 cc's, 50 cc's. It's impossible to do that with them because of this irrigation that's going on. And you can speed the irrigation up if you want it to run faster if they're bleeding, or you can slow it down. And it's usually used in a three-way catheter. One catheter goes to the bag, the urinary bag. One goes to the irrigant solution, and then the other one is the balloon that holds the catheter in place in the bladder. These catheters are usually taped very securely to their leg because we want it to hold tension so it'll stay in place. Now back to the TUR syndrome. You don't see it that often, but the symptoms can vary and they can be very unpredictable. So some of the symptoms can be confused with other things too. So you just really need to be on your toes about this and make sure that you pick up on it quickly if there's a change in the patient. But for central nervous system disorder or conditions that you're looking for is things like restlessness. Do they have a headache that they have not had before? Nausea and vomiting is very common with this particular type of syndrome. Are they confused and they weren't confused before surgery? But then we have to decide, well, is it the sodium, or is it the anesthesia that has made them confused? So they can be, like I said, the symptoms can be easily confused with so many other conditions, but you just really need to be on top of any changes. And then, of course, if it's not treated, seizures, of course, can occur due to the cerebral edema, and then coma and potentially death if it's not treated promptly. Cardiorespiratory signs and symptoms that you may see, they may be bradycardic, which means their heart rate is below 50. And their blood pressure may be up or it may be down. That's very individual and it's unpredictable. They may also have some tachycardia if they are having respiratory distress, along with like the hypoxia and the cyanosis. Pulmonary edema can also occur because of all the fluid that's been absorbed. And where is it gone? It's gone into their cardiovascular system and then on into their lungs. They may also complain about abdominal pain and distension, but this is usually not like right early on as soon as you're going to see the nausea and vomiting or the confusion. But some of the systemic things that you may see is hypothermia, as well as the abdominal pain and the distension. So just keep that in the back of your mind when you're caring for these little old patients. If they start getting confused or doing squirrely things that don't seem quite normal, then, be sure to call your surgeon and ask them about getting some lab work if the patient hasn't had any done. And so basically the treatment for this is to stop the irrigation if we possibly can. Unfortunately, there's no definitive diagnosis. We just have to look at the sodium to see if it's less than 120, and their potassium may also be elevated. But now some people respond to a sodium in different ways. So theirs may not have to get down to 120 for them to be confused, complaining of a headache, restless, all those things that go along with cerebral edema. And then, of course, DIC is also a complication that may occur with it. And that is where you have, are y'all familiar with DIC? Yes, no?
I'm not.
No.
Okay. Basically what it is a blood dyscrasia. And it can be brought on by a syndrome like this, it can be brought on by sepsis, it can be brought on by trauma. And basically what happens is that we have a reduced number of clotting factors, platelets, and then there's an increase in the fibrin degradation products in the blood. And what happens is there's these teeny, tiny little microemboli that form everywhere in the vascular system. And the patients bleed from every orifice that they have. They bleed from their nose, their mouth, their eyes, their ears, everywhere. That can happen with these particular patients too. So that's something that we don't want to see happen, and we want to be on top of it and get it resolved before it gets to that point. And we've already talked about some of the signs and symptoms, and we've also talked about the hyponatremia, which is the dilution of the sodium, what little sodium there is left. And then there's one of the irrigation solutions. Now, I'm usually most commonly familiar with using normal saline to irrigate with, but there is another solution. It's called glycine, and one of the byproducts of it is ammonia. So an encephalopathy may also occur, particularly if your patient has liver problems anyway. So if they're using the glycine instead of the normal saline, and you know your patient has a history of cirrhosis or some other liver issues going on, maybe liver cancer or something like that, then, watch them very closely, because they can certainly develop an encephalopathy from that. And it can, of course, lead to heart failure as well. So, how are we going to prevent this particular syndrome from happening? Well, we can use regional versus general anesthesia. The main thing is early detection. Be on top of it. Be paying attention to that patient. Know if there's a significant change in their behavior. How long were they under? If they were under general anesthesia, were they under 45 minutes, an hour, or were they under 2.5 hours? And it makes a difference, especially if it's an older person. How were they positioned during surgery? That can make a difference too, because certain ways that they can be positioned reduces this intravesical pressure, which is required to initiate the absorption of this irrigation solution. So, and we don't have any control over that. It's just helpful to know if they were in horizontal Trendelenburg or whatever. And another helpful tip is to make sure that the irrigation fluid is no higher than 60 centimeters above the patient, because this is going to minimize your hydrostatic pressure of the fluid, because it flows by gravity. So if you can keep it no more than 60 centimeters, then that's going to help with that force of gravity. So how are we going to care for a patient that has had a TURP? Well, we've already talked about how those catheters are taped in place really tight. The patient's going to complain of some bladder spasms, so we're going to need to have them on some type of an antispasmodic. Try to keep their leg as straight as possible to keep that catheter straight and the tension taut on it. Maintain the irrigation flow. That's something that you'll just have to monitor hour by hour, because it depends on how much the patient is bleeding. If they're bleeding a lot, you're going to want to irrigate it more, because you don't want that blood to have a chance to sit in their bladder and potentially cause them to clot off and not be able to void. What you want to measure the urinary flow. We already talked a little bit about that. And how to do that. That's very, very important. And if you notice that your patient's having a lot of bleeding, like a lot of bright red blood in their catheter, and maybe the surgeon didn't order any more lab work till in the morning, you might want to call him and say, hey, listen, Mr. Smith is really having a lot of bleeding from his catheter. Could we probably do another H&H maybe at 10 o'clock tonight or something like that, so that you're on top of that, and we don't get him into a hypovolemic state in conjunction with all of these other problems. And with these catheters are a little bigger than your regular 14, 16s. So the patient's going to feel like they have to pee all the time. And that's going to be one of their major complaints. They're going to have the bladder spasms. So it's going to be important to keep them on this antispasmodics and control their pain as much as we can. We want to maintain an adequate intake, and that's usually around 2,000 to 2,500 per day. However, just remember that that all depends on your patient, because if they have other comorbidities, then this may be too much fluid for them. So we may have to adjust that. And then, of course, they're going to go home with the catheter in place. So when they go home, you want to make sure that they know how to take care of this catheter, that they know how to empty it, or that somebody in their family is available to help them with it. And the main thing we want to protect the patient from in the hospital is from pulling that catheter out, because if they pull that catheter out, what happens is that it's almost impossible to get back in without them having to go back to surgery, because that tissue is so swollen and irritated from the surgery that it just closes off right away. So it's almost impossible to get it back in without having to take them back to surgery and sedate them.
Miss Bowie, how long will they keep the catheter after the surgery?
They usually keep it anywhere from 7 to 14 days. It depends on the patient and the doctor.
Okay, thank you.
But the reason that we leave it in is to give that inflammation and that swelling a chance to resolve, because if we take it out too early, they're not going to be able to pee. So we're going to be right back to square one.
All right, thank you.
We want to give them plenty of time to heal enough that they will be able to void without any complications. Some people believe in the complementary alternative medications, such as the saw palmetto and the pumpkin seed extract. Thing I would encourage you to tell your patients is to do their research, because there is not a lot of supportive evidence out there that shows that these are truly effective. But, you know, sometimes I think it's a situation of mind over matter. If they think it's helping, then maybe it is helping. I don't know, you know. So what are some non-pharmacological management techniques that we can put into place? Well, we have to decide, first of all, how limiting are the symptoms? Are they making you very, very uncomfortable, or is it just a little uncomfortable? Do we want to wait and watch them and do our annual evaluations? Is there lifestyle modifications that we might be able to implore with these people, and maybe having them avoid fluids prior to bedtime or prior to going out? If they're going out to the mall or going out to play golf or whatever, maybe avoid the fluids. However, now you have to be mindful about the fact that these are older people, so they don't get thirsty like younger people do. So when they start getting dehydrated, they're probably not going to be thirsty. So we need to be very mindful about that too, because we don't want them to stop taking fluids at 12 o'clock and not take any more until like 8 o'clock the next morning, because that would not be a good thing, because that will get them on the other end of the spectrum, and then they'll be dehydrated and potential for urinary tract infection and all kinds of other problems. So, but if we can get them to maybe stop drinking fluids around 6 o'clock in the evening, maybe that will help them be able to sleep more restfully at night. Or maybe they need something like Lunesta or something like that, so that when they get up and they go to the bathroom every 2 hours, they can go back to sleep readily when they get back in bed, and they're not left awake for 2 or 3 hours after going to the bathroom. Caffeine and alcohol are stimulants, so that can certainly make our bladder overactive. Encourage them to go to the bathroom at least every 3 hours, particularly during the waking hours. And then try the double voiding. After they've voided, have them to wait just a minute or so and then try to void again to see if that they can get the rest of that residual urine out of there. So let's talk briefly about some of the psychosocial aspects of BPH. Well, depression is a biggie, rightfully so, because they feel like they are tied to the toilet. They're going to be irritable at times because think about all the interruption that they're having in their sleep. Every hour and a half, 2 hours, they're having to get up and go to the bathroom. And then it takes them 30 minutes to an hour to get back to sleep. And then in another hour, it's been 2 hours. It's time to get up and go again. So they may be a little cranky and irritable because they've not been able to have any uninterrupted sleep. They may be embarrassed to discuss this condition with their physician or the nurse. They may feel like that they have a lack of control of their elimination, and they do sometimes, because if they're incontinent, they can't help that. Then they're going to have to use the adult Depends or something like that, and that may make them very self-conscious. They may feel socially isolated because they don't feel like they can comfortably go out in public. And they also may have some problems with sexual function. They may actually have a decreased sexual drive, and they may have some erectile dysfunction related to this as well. So, all right. Do y'all have any questions?
No, ma'am.
Okay. All right. Then why don't y'all take about a 5-minute break, and then we'll come back and do erectile dysfunction in your review, and you'll be all set.
Okay. Thank you.
You're welcome. Okay. Our last topic. I know that, let me just say this. I know that this is a massive amount of information, a massive amount of material, but we're going to do a review and try to narrow that down for you whenever we finish this PowerPoint, so that will help you to narrow down what you need to focus on. Okay.
Yeah, that's going to be greatly appreciated.
It is a tremendous amount of information over such a short period of time.
It is.
Correct.
Okay, so we're going to talk about erectile dysfunction now. And the objectives, I have the objectives posted for you. Not going to read those. So basically, the definition of erectile dysfunction is the inability to achieve and maintain an erection for intercourse. Now, don't confuse it with decreased libido, because it is not the same. And it can be caused by medical problems, or it can be caused by psychological problems as well. Or it could be a mixture of the two. I put this picture in here so that you could just kind of get an idea of how the process occurs as far as the erect state and the outflow of blood, and the flaccid state, and how the arterial blood flows inward. And that's just a visual for you. I'm a visual learner, so I try to include pictures for you when I can to help make it a little bit more understandable. So basically, I'm not worried about you knowing about this on the test, but the nerves that are involved are the parasympathetic nerves, which is sacral 2 through 4, which helps to initiate the erection. And then T11 through L2 help control ejaculation and the subsiding of the erection. There again, that's just a little bit of anatomy and physiology about an erection. It's not something that I'm going to ask you about on your test, because I don't think you need to know this to take care of your patients unless they have a spinal cord injury. And then you have a whole host of other issues to be concerned about. So let's talk a little bit about well, first of all, there's two basic kinds of erectile dysfunction. There's one that is called organic, and it's where you have a gradual decrease in function, meaning that maybe a year, 2 years ago, they were functioning fine, and now 2 years later, they're not able to maintain an erection. That can be an organic situation, and that can be caused by a number of things, such as inflammation of the prostate. It can be caused by the prostatectomy that we talked about earlier, the TURP. Any type of lumbosacral injuries can cause the organic problem. Any type of chronic neurological problems, such as Parkinson's disease, stroke, MS, even being tired can make a difference as well. Endocrine disorders such as diabetes and thyroid problems can also relate to the organic dysfunction. Smoking and alcohol is other factors that can cause hypertension. Is going to be one of your most common complaints that you're going to hear from with your patients, because they take the antihypertensive, which is usually the first line is beta blockers, and then they're not able to have erectile function. So poor overall health can also contribute to erectile dysfunction, especially if there's any type of kidney disease or liver disease, prostate enlargement, like we talked about before, cholesterol levels too. Sometimes the first inkling that we have that a patient has cardiovascular disease is they present to their doctor with erectile dysfunction. So then they start working them up and realize, they have pretty significant cardiovascular disease that we didn't know about, which it makes sense because that's very vascular, and it requires and depends on a good blood supply. So if the blood supply is not adequate, then they're not going to be able to perform sexually as they should. The other classification is functional. And basically this one is very sudden. The onset it's usually some type of stress or some type of a psychological event. It can be self-image. It can be maybe they have embarrassment about something. It can be anger. Typically, when this particular type of situation occurs, the medications are not going to be effective or as effective. Now, whenever we were talking about the low libido, it's not the same as erectile dysfunction, but a lot of the same factors can affect it that affects the erectile dysfunction. Okay. So we've already talked a little bit about, psychosocial issues that can come into play. What type of relationship are you in? How long have you been in the relationship? What type of relationships have you had in the past? Is your partner having issues? If your partner's having issues with menopause to where intercourse may be painful, that may be a problem interfering with the male erectile function. So it can be a combination of things. And we've also talked a little bit about the psychogenic and the psychiatric causes that can occur with the erectile dysfunction, relationship difficulties. Maybe they've lost the attraction to their partner. Maybe they've suddenly become depressed, or maybe something has happened in their life that has caused them to become depressed. And then we also have, we talked a little bit about the endocrine disorders, but if they have a low testosterone level, that may also be a contributing factor. Do y'all have any idea what the normal testosterone level is? Well, I'll tell you, it's around 300 to 1,050 deciliters. And this does decrease with aging. So you may have a guy that is taking testosterone supplements in order to improve his sexual function. And then your SHGB, which is the sex hormone binding globulin, it's made by the liver. So, and it binds with estrogen and the DHT and testosterone in men and women. So that may be, if it's elevated, that may be a cause of dysfunction. And then, of course, prolactin is secreted by the pituitary gland. So if it's elevated, that might be a problem. Anything that would affect your pituitary gland might be a contributing factor to erectile dysfunction. So if it's benign tumors, malignant tumors, any type of a pituitary disorder may reflect in erectile dysfunction. So how are we going to assess these patients? What are some things that we're going to ask them? And this can be very sensitive for the patient. So just be very mindful about that they may be very self-conscious and very embarrassed about it. So we really have to be professional whenever we are questioning these patients about these problems. You want to find out what type of medical history they have. What kind of medicines are they on? Because that can make a big difference. If they're on certain types of blood pressure medicines, maybe they're on some chemotherapy drugs that might make a big difference. We want to also check any psychosocial disorder or conditions that might be causing a problem. What about their desire, their sexual desire? Do they have the desire, but they don't have the ability to function? So that's where your libido comes in, as to whether they have the sexual desire or not. Any type of ejaculatory disorders. Do they have premature ejaculation or retrograde ejaculation? What type of quality of life do they have, and what are they wanting to get out of the treatment? So we're going to, of course, ask them all their medical questions. Have they had any surgeries, any back surgeries, pelvic surgeries, any pelvic injuries, pelvic fractures that might be causing a problem? And do they use any type of recreational drugs that might be contributing to their erectile dysfunction? Now, these are your typical drugs that are associated with the erectile dysfunction. Your antihypertensives, your antidepressants, anticholinergics, antipsychotics, anxiolytics, and your psychotropic drugs. So, and these are just a few. I mean, there's many, many, many drugs, but I just tried to pick the most common ones that you would see and deal with in the clinical setting when you're dealing with the patients. So now we're going to do our patient assessment, like our physical assessment. So we want to assess their blood pressure, because that's going to give us an idea of how well blood's perfusing to that area. What's their peripheral pulses? Are they being perfused very well? Are we able to feel them? Do they have an abdominal aortic aneurysm? If they do, that's a ballooning in the aorta, which is the main vessel that runs down the center of our bodies. Then the blood flow may be close to, may not be close to what it should be for the kidneys. Just got an alert on my phone. Did anybody else get one?
Yeah.
Okay, what size are their testicles? Is one smaller than the other? Is one ascended? Or maybe it is partially ascended, it's not complete, or partially descended. It's not completely descended. Are they hard? Are they soft? Are they spongy? What type of consistency are they? Do they have any secondary sexual characteristics like hair in unusual places, or maybe the sounds of their voice is a little different? Things like that are things that we're going to be assessing for. Anything that's different that you just doesn't fit the normal picture. And then, do they have any type of it's called Pyrenees plaques, this fibrosis, which is scarred tissue in the bend in the penis that causes it to bend, so it can't be straight. So they may have that problem, and there's medications out that can be helpful with that. And then phimosis is a narrowing of the opening of the foreskin, and it's where they can't retract the foreskin over the head of the penis. And you see this sometimes in older guys. You may see a 73-year-old patient that comes in and you're thinking, why is he coming in for a circumcision? Well, it's because this has happened. The foreskin has narrowed so much that he can't retract it over the head of the penis, and either he has a problem with voiding, or he may have a problem with personal hygiene as well, because he just cannot get in there to clean it. If they've had a circumcision, then we don't have to worry about this. That's not going to be a problem for them. But it can be very, very uncomfortable, a very uncomfortable procedure for a patient with, especially an older patient. So it's not uncommon to see them come in because you think, well, they've made it 73 years without one. Why do they need one now? And it's because it's causing them problems. Okay, some of the other things that we've already talked about is let's see, I don't know why we went backwards, but anyway, let's talk a little bit about some of the testing that we're going to do with these patients. Well, we're going to consider doing a glucose and lipid level, because this is going to help us know if they have any type of cardiovascular disease or diabetes that may be contributing to their problem. What's their testosterone level? Is it within the therapeutic range, or is it low? How is their thyroid functioning? Because, when their thyroid's not functioning well, it makes them feel really tired, and they feel very sluggish, and they just don't feel like themselves. We may want to look at the PSA as well to make sure that we don't have any type of prostate cancer going on in there that we didn't know about. And then, of course, urinalysis is going to help us determine diabetes, as well as any other potential renal issues that may be going on that we don't know about, that may be contributing to the fact that they cannot perform adequately. So what type of specialized testing can we do for these patients? Well, there's a couple of vascular studies that we can do. The main one is the ultrasound, or a duplex Doppler is also another procedure that is used. And it assesses the blood flow to the penis. How well is it being supplied with the blood and the nutrients that it needs? And remember, blood carries oxygen and nutrients. So if that area is not getting the blood and the nutrients and oxygen that it needs, then it's not going to be able to perform adequately. We're typically going to do this testing in the patients, very young patients who have ED, because we want to look and see if there's anything vascular going on there, or anybody that may have had trauma to some type of motor vehicle accident, or maybe they were thrown off of a horse, or maybe they've had a penile fracture in the past, and those are very, very painful. One other condition that I wanted to mention to you too is priapism. And that's an erection lasting longer than 4 hours without stimulation. That can be an area of concern, and we'll talk a little bit more about that as we go on and talk about medications. And then if the patient is not responsive to to the medical therapies that we have in place, then, okay, well, now what? What's wrong? What's causing this problem? Why can why are the medications not working? Is there something else going on that we don't know about? And years ago, we used to do a penile implant. And when they first came out many, many years ago, they were rigid, which was just like a rod that was placed inside the penis. And they were pretty much semi-erect all of the time. And then as technology advanced, so did our methods for the penile implants. So now they have the implants that have a pump. It has a little valve that also goes down in the scrotal area, and you can pump up the cylinder that has been inserted in the penis. And then once they are finished with the sexual act, they can let the air out of it, and then it goes back down. So that's really come a long way in the last 2 or 3 decades. So that's an option, but we really don't see that done that much anymore because we do have all these nice drugs that we can use. And I just wanted to go through some of the therapies and treatments that are available for these patients, so that if you encounter a patient with this condition or concern, that you're able to answer their questions as accurately as possible. And we may not know all of the answers, but at least we'll know in what direction to point them in so that they can get those answers to those questions, because this is a very big concern for males. So let's talk a little bit about some of the medications for erectile dysfunction. We have the oral agents, which are the centrally acting dopamine receptor agonist medications, and then we have the PD5 inhibitors. That's what we primarily see used the most. That is your first line drugs right now, and that's the Viagra, Levitra, Cialis. And these are usually effective within about 30 minutes to an hour after taking them. So it does take away a little bit of the spontaneity, but at least they are still able to be able to perform sexually. Intracavernosal is another method that can be used sometimes, and this is where there is an injection into the penis with vasodilating drugs. And then there is an intraurethral method as well, to where a tiny little like a suppository type, I guess it's actually a pellet, is actually inserted into the end of the penis through the urinary tract that causes an erection. And we'll look a little bit more at those in just a couple of minutes. So we've already talked a little bit about the PDE5 inhibitors. They have about a 4 to a 6 hour window that Viagra does. Now you have to be careful with these medications if they're taking any type of blood pressure medicines, particularly nitroglycerin. You do not want them to take nitroglycerin with these medications, because it can cause them to have a hypotensive episode. Cialis, tadalafil is usually taken about 30 minutes before the sexual activity. This is one that is called the weekend drug because it has a 36-hour window. And this is also a drug that can be taken in small amounts, like 2.5 milligrams every day, so that you have more spontaneity than you do just taking the 10 or 20 milligrams, every Thursday or whatever works for the individual. The absorption of this particular medication is usually not affected by food intake. And then the Levitra, which is an older one, and I really haven't seen it used that much in a long time, because the Viagra and the Cialis are so much better and so much more effective. But it's usually taken anywhere from 30 to 60 minutes before sexual activity. And of course, it can be the absorption can be delayed if the person has maybe just had a big, heavy meal. So they need to keep that in mind. And when we're educating them, make sure we educate them about that. And the tadalafil is not usually affected by food absorption. Okay, some of the side effects of these medications. The main thing that you're going to see with these patients is facial flushing and nasal congestion, and some may complain of a headache. Some may complain of visual disturbance. That's not that often. Priapism is also another side effect that we need to be concerned about, because if they have a priapism and it's an erection that lasts longer than 4 hours, then there needs to be some intervention, because what happens is the blood supply is limited to the penis because it's so engorged. So it can suffer permanent damage if there are no interventions, and it remains erect for over 4 hours. And then with this group of medications, we can sometimes see ischemia to the optic nerve, but that's not that often either. The main things you're going to see is the facial flushing, the headache, and the nasal congestion. Those are the main things that they're going to report to you about. So what are some contraindications for the PDE5 drugs? If they've had any type of a cardiovascular event, if they've had an MI, if they've had stents, if they've had bypass surgery, anything like that, we want to avoid this group of medications. Nitrates, such as I mentioned before, because of the potential of causing a hypotensive episode. Any type of anatomical deformity, if there is Peyronie's disease or any type of cavernosal fibrosis, anything that's going to restrict the potential for the penis to enlarge, because that too can cause permanent damage. And then we've also mentioned earlier about prolonged erections. Sometimes you see that in sickle cell patients, because the sickled blood cells actually block the blood in the penis and don't let it out. And that can be a problem because it deprives it of oxygen and nutrients. Some chemo drugs may also cause problems. Stem cell transplants can also lead to prolonged erections. Leukemia, priapism is a lot of times the first manifestation of chronic myeloid leukemia because of the microemboli that cause the venous obstruction in the vascular system. So sometimes they go in and they're complaining of priapism, and then when they're worked up, they discover that they have chronic myeloid leukemia. And because of all those little tiny microemboli that have occluded the vascular system within the penis. Okay, some of the drug interactions that we talked about is the nitrates. You want to be careful about those nitrates with these medications. They should not have any nitrates within 24 hours of taking Viagra or the Levitra. Now, the tadalafil is recommended that they don't have nitrates for 48 hours. Other medications such as your cimetidine, ketoconazole, and erythromycin are also contraindicated. Any type of the alpha blockers, the ARBs, diuretics, because this is all going to affect your cardiovascular system. It's going to vasodilate or pull off fluid, like with the diuretics, and it can cause you to have episodes of hypotension, which is not what we want, because the last thing they need is a head injury from a fall. Okay, the intracavernosal injections, typically these have to, it doesn't matter if they have an intact nervous system or not, because usually it can still work even though their nervous system may not be completely intact. Now, the problem with this is that they have to be able to have good vision to be able to see what they're doing and draw the medication up. They have to have the manual dexterity. So if it's somebody that has very bad arthritis, then this may be a limiting factor with them. And then, of course, they have to be able to be able to train them. They have to be teachable so that you can teach them how to do it. We don't give this particular medication to patients who have any type of bleeding disorders, if they have sickle cell anemia or the multiple myeloma or leukemia, because we've already talked a little bit about that and how the microemboli or the sickled cells trap the blood in the penis. Some of the main side effects of this particular type of medication is going to be the penosacral pain. They may have a hematoma at the injection site, and if they use them a lot, they may actually develop fibrosis at the injection site. Now, I wanted to show you some pictures of these so you can kind of have a visual of how these are actually done. So you can see in this picture, the patient has to, of course, have good dexterity because he's got to be able to hold the syringe and then hold his penis as well. And then he has to be able to inject it and inject the medication as well. So you can see why, if you did this over and over and over and over again, that it might be a problem with fibrosis developing. Okay, and then the Muse system is another system that is used. It's a medicated urethral system for erection. And this is where the little pellet is inserted with an applicator. And then once the little tiny pellet of medication has been inserted, the penis is massaged to aid in the absorption. The main thing that these patients are going to complain about is the penile pain. They may complain of some burning from the medication. They may complain of some dizziness. Priapism is very rare with this particular type medication. However, this is probably one of your least effective forms of medication as well, too. It's not nearly as effective as the injectable form is. So it may work, it may not work. But if the patient is at a high risk for, let's say that it's maybe a chronic renal failure patient or a patient that has severe cardiovascular disease, either the Muse method or the intracavernosal may be your best options rather than giving them some type of the PDE5 medications. Okay, and this is a picture of the intraurethral, the Muse method. So you see they have a little tiny applicator that actually puts the pellet into the penis. And then this medication is absorbed there because this is very vascular tissue. So it has a good blood supply. So it's going to absorb it quickly and hopefully cause an erection for them. A couple of other methods that I also put on here for you that really don't involve any medication at all. If you have a patient that may not be a candidate for any of these types of therapy, then the vacuum method may be very helpful for them. We just have to be very mindful that they know to not leave it on more than about 30 minutes because it compromises the blood flow at that point, the ring at the base. So we don't want to do that. We don't want to cause any damage. So they want to watch cyanosis, edema, coldness of the extremity, just anything, just like you would lose the blood supply to your foot or your arm. What are you going to be looking for to assess the circulation? Well, you're going to be looking to see if it blanches, if it's purple or blue, is it swollen beyond what it should be? we need to be very mindful and make sure that we've educated our patients very well if this is a method that they choose to use. And there again, we don't encourage the use of it with congenital bleeding disorders and sickle cell disease and some forms of leukemia and priapism, as we talked about before. Nasal sprays are also effective for people who have premature ejaculations. And I really don't know, I don't know that I have encountered very many patients that use this, but there's not a whole lot of research out there that supports the data on this. So hopefully as time goes on, there will be more research done on it. It'll be a little bit more supportive of all of that. And then I've already talked to you about the penile implants, and the risk factors that are involved with these are, of course, infections, and we can destroy the good tissue in there. It can erode through the tissue, particularly if there's any type of injury to it. And then, of course, it can have mechanical failure. It may have to be replaced. It may not work after it's been inserted, and they may have to have it replaced, or they may opt to not have it replaced. If it's somebody that has a lot of comorbidities, it may be more risky to replace it than to just leave it. It's not going to hurt anything where it is, as long as it's not showing any signs of infection and it's not eroding any of the tissue. It's fine to leave it. So let's talk a little bit about some of the psychosexual therapy concerns that these patients have. Even if the problem is physical, the patient is still going to have some psychosocial issues because they're going to be very anxious about performing adequately. They're going to be nervous. Are they going to be able to perform? Will I be able to perform long enough? So all of those things are things that we need to think about when we're caring for these patients. And there may be certain types of exercises that may be sexually arousing to them that might be very helpful once them and their partner explore that territory. They may find that there's certain things that are just very appealing to them that make the erection much easier. And then they also may need some relationship counseling if they're having issues within their relationship. So, what are some of the treatments for erectile dysfunction? Well, it's just like our general health. We want to get them to stop smoking, or at least reduce the smoking, reduce their alcohol intake, encourage weight loss if they're overweight, encourage some type of a regular exercise program. And then, of course, our role as far as nurses is that we need to be aware of the high incidence of erectile dysfunction and how it can have an impact on the patient as well as the partner. We also want to be aware of the high risk factors, the causative factors that put our patients at higher risk for developing this condition if they don't already have it. And then we have to be able to discuss with the patient the information that's available and to educate the patient on what's available. And you have to be able to be comfortable with it enough to discuss it openly with them, because they already feel bad enough that they have the condition, and then they're having to openly talk about it with other people, and that can be very embarrassing to them. So we have to put ourselves in a non-judgmental position when we're talking with them about these situations. So, in conclusion, erectile dysfunction is a very common problem. It affects both the patients and their partners. It can be a combination of psychological as well as physical components. And it may be the initial presentation of diabetes or coronary artery disease, which I told you that earlier on. There are a lot of good, safe, effective therapies out there that hopefully could be helpful with the patient and help them become more sexually active and be more comfortable in dealing with your erectile dysfunction. And if you don't ask your patient's probably going to be too embarrassed to just outwardly tell you that, I'm having a problem with this. So it's important that we, as healthcare providers, explore these options. And one other thing that I did not mention to you is that we were talking about exercise. Some research has shown that the shape of a bicycle seat may actually cause a problem because it causes pressure in the perineal area, which is the area between the anus and the scrotum on males. So if it's a person that does a lot of cycling that's having a problem with erectile dysfunction, it may be that they could change the seat on their bike, and that may be very helpful to them, because it's just little things like that you don't really think about until you start talking with your patient and asking them, and well, that's a pretty easy fix if that would help the problem. So do y'all have any questions for me? No questions?
Nope.
Okay. Okay. Let's see. Somebody asked me about the medications on the test. They will be generic because that's what's on NCLEX, and that's what my mission is, to prepare you as best I can for NCLEX. Now let's go over. Do y'all need a break again? Do you need another break? Yes? No?
I'm good.
Good. Okay. Then we'll move on. We'll do our little review, and then you'll be all set. Okay. Now let's talk first of all about peptic ulcer disease. What kind of medications do you want to avoid with peptic ulcer disease?
NSAIDs.
Okay. Give me some examples of NSAIDs.
Ibuprofen.
Okay. What else?
Is this the one you want to avoid aspirin as well?
Mm-hmm. You're right. Absolutely. Because remember, aspirin is a platelet aggregate. So it's going to irritate the gastric system, and it can cause ulcers to develop. Steroids, we want to stay away from steroids. We want to stay away from ketorolac, which is tramadol. That's the generic name for tramadol. You want to stay away from that. Ibuprofen, all of those, all of the NSAIDs as much as possible. What type of foods do you want to try to avoid with peptic ulcer disease?
Any that cause discomfort to the patient.
Okay, and that can be very individual, but we know that the caffeinated beverages and like coffee, tea, cola, alcohol, that's a stimulant. Those are things that we know that we want to stay away from as well, because that can predispose us to developing ulcers. Now, what are some complications that can result from peptic ulcer disease?
Perforation.
Okay, what else?
GI bleed.
Hemorrhage. And what happens to that little old pyloric valve, pyloric area?
Stenosis.
Obstruction, yeah. Because what happens is there's scar tissue that forms down there, and it causes it to thicken. So that's the outlet that the food goes through to get into your small intestines, right? So that can be a problem with peptic ulcer disease. If you have a person, let's say you have a patient that comes in, and let's say that the doctor has ordered 1,000 cc's of normal saline every 12 hours 800 milligrams of ibuprofen every 8 hours, 200 milligrams of amlodipine every 2 hours or every 12 hours. Which one of those orders would you question?
Ibuprofen.
The ibuprofen, right. Okay. Now, if we're talking about, let's talk a little bit about ulcerative colitis. If we're talking about a person that has had diarrhea for, let's say, a week, what are some things that we're going to be concerned about with this patient? What are some nursing concerns?
The electrolytes, dehydration.
Okay. What else?
Skin integrity.
Yep. Good. Yay.
Thank you.
Because they're going to be pooping like a little goose, and then they're going to have all kinds of rectal irritation. So that's going to be a problem for them. When do we want to give PPIs?
Pump inhibitors.
Stress.
Lori.
When do we want to give a proton pump inhibitor?
Stressful events.
When do we want to give a proton pump inhibitor?
Before meals?
Yeah.
Surgery.
Yes, 30 minutes before meals.
Right. Okay. Because that's like Pepcid and the Prilosec, correct?
Uh-huh. Yes, ma'am.
Okay. Yep.
Yes, ma'am. It is. What do you want your stoma to look like? If you have a person that comes from surgery, what would you expect their stoma to look like?
Beefy, red, and moist.
Yeah, you want it to be really red and moist. Now, if you have a person that has colon cancer in the lower part of the colon, in the rectal area, what complications of the surgery might that person expect to have?
Rectal bleeding.
Rectal bleed with mucus.
You're going to see that more with your A and P resections. Think about this. Where does the rectal area sit? What does it sit next to?
Urinary retention.
Okay. They may have actually incontinence because that urinary tract may have been, the nerves to it may have been disturbed when they did the surgery. So if they have that, what do you think about sexual dysfunction? They might have sexual dysfunction too, because you may have an interruption of those nerve paths, right?
Yes.
Okay.
Makes sense.
What if you have a person that tells you, let's say that they have colon cancer, and they tell you that they just do not want to have the surgery. I just don't feel good about it. I just do not want to have the surgery. How would you handle that therapeutically?
You can
Ask them questions why.
but not
Or ask them what their concerns are.
Okay.
because you want to kind of get an idea of what it is that is having them so apprehensive. Is it because they feel like they haven't gotten enough information about the surgery? Do they feel like because it'll affect their home life balance, stuff like that, maybe?
Okay. And you want to make sure that they understand what they've been told, because I'm going to tell you, you will find quite often that when you start verifying your perceptions of what that patient was told, and you may be in the room when the doctor's talking to them, and you know exactly what that doctor told them, but that was not the way that patient perceived that conversation at all. So you always want to be sure that you verify that, did you perceive this? How did you perceive this? Or what did you take away from this conversation? Okay, if we are going to, let's say if you have a patient that says, I don't really think I want to have surgery. I think that maybe they have colon cancer. I think I want to do the complementary alternative therapy. What would your position be as a nurse with this patient?
So tell them to make sure they do their research before.
Okay. Yep.
Give them
Because
the benefits of it.
I'm sorry?
risk versus benefit? You know, we can kind of mention that.
Well, at this point, they're just trying to decide if they want to do the therapy as opposed the complementary alternative therapy. So you want to steer away from them giving them your opinion, because that's what they're seeking a lot of times. Well, what would you do? And it's like, well, you know, you can't really tell them that, because what might be right for me might not be right for you, and they have to decide for themselves what is the best thing for them to do. If let's say that we have a patient that is going for a lithotripsy, what complications can we anticipate to tell them about post-operatively or post-procedure?
They may see some
Bruising.
bleeding and
Okay.
bruising.
Okay. And before we send them, what are some things that we want to make sure that is in place before we send them to the procedure?
Informed consent.
Okay. What else?
Post-operative directives.
Okay. We want to make sure they have an IV.
Oh yeah.
Yep. Because if you send them without an IV, the lithotripsy team's going to be screaming at you. Why did you send that patient down here without an IV? And we also need to make sure that they're NPO, because if anything happens to them and they need to go to surgery, the anesthesiologists do not like for them to have a full stomach. So we want to make sure that they are have remained NPO. So let's talk about, let's talk a little bit about hormone therapy for prostate cancer. What is the primary goal of prostate hormone therapy for prostate cancer?
To decrease the testosterone level, to get rid of that hormone.
Yeah, we want to decrease those androgens as much as we possibly can. What about if we have a patient that has kidney stones and we are educating them about how to care for themselves at home? What are some things that we're going to want to check to make sure that they understand?
Diet.
Okay.
How to strain the urine.
Okay.
Finish all their medications.
Yep, finish all their medications. And if this patient says, well, now I know I'm supposed to limit my fluid intake to 500 cc's a day, what does that tell you?
Further teaching.
That you missed the point. They've missed the point somewhere, unless they are either renal failure or heart failure, and they're having to minimize their fluid intake because of that. With your erectile dysfunction drugs, are they going to be very effective with psychosocial disorders?
No.
No, they are more likely to be successful with organic disorders like your cardiovascular disease, your hypertension, and things of that nature. Now, if we are assessing a patient that has, let's say they have metastatic colorectal pain or cancer, and then they're having significant pain, how are you going to assess this patient's pain, and what is going to be the most determining factor as to whether you give them more pain medication or not?
If
What's
it
metastasized, you want to keep them comfortable.
I'm sorry.
Level of consciousness.
Okay. All right. And we want to know what the pain is to them. We want to know what their level of pain is, because you can walk in and a patient may be laying there with their eyes closed, and we talked about this too the other day. And just because they have their eyes closed doesn't mean that they're asleep. That just may be the way that they handle the stress of the pain. So we want to make sure that we assess how they score the pain. because that's going to make a difference in whether we give them 1 Percocet or 2 Percocet, too. And of course, like you said, we definitely want to assess their neurological system as far as making sure that they're not over sedated and that their respirations aren't poor. If we are wanting to confirm a malignancy, what is the best test that we can do to do that?
Biopsy.
Biopsy is going to definitely confirm it, because we can actually get a sample of the tissue and analyze it in the lab. If you send the person home with a catheter, let's say they've had a TURP, well, we know that that can cause urinary incontinence. So they need to know that, because if they go home and they don't know that, and then after their catheter is taken out, they start having incontinence, they're going to think something is terribly wrong. So we want to make sure that we educate them very well on that. And what do we want to teach them as far as management of the catheter when they go home? How are we going to teach them to care for it?
Clean around the catheter site.
Yep, clean it with soap and water and make sure that they keep it below the level of the bladder without any kinks in it, because we don't want that urine to back up in the bladder, because that's going to predispose them to a urinary tract infection. What is the characteristics of a malignant prostate gland? What is a prostate gland that is malignant? What does it feel like? Is it soft or mushy or firm?
Hard.
Okay. It's hard and firm. And just think about the other nodules that you've learned about with cancer, because they're hard and firm too, like breast nodules. Think about that when you're thinking about that. Now, if you have a person that, let's say that they have had a TURP and their blood pressure is, let's say, 102/54, and their heart rate is above 130. Would that be area of concern for you?
Yes.
Okay, why?
Return syndrome.
Okay, and what else? What else might be going on? Especially if they've lost a lot of blood.
A hemorrhage.
Hypovolemia may also be a problem. So we would definitely want to notify the physician so that we could do our lab work to see which it is, if we can't tell by looking at the patient. How could we tell by looking at the patient which it might be? How would we determine? If we thought that it was hypovolemia, what might we base that on?
They could be pale.
Diaphoretic.
Okay. Blood loss. How much blood do they have in their catheter bag? Are they bleeding a lot? Okay. All right. So those are some things that we can definitely think about. Now, what about your PSA level? What's your normal PSA level?
2.5.
0 to 2.5.
Okay. And if the person is, say, 70, 75, would it be expected for theirs to be maybe more elevated?
Yes.
Will be elevated.
It might be normal for them to have a higher PSA than what the 50-year-old would be. What are some symptoms of erectile dysfunction, like physical symptoms that we are looking at when we are assessing our patients?
Maybe a high blood pressure.
Well, we're looking at characteristics. So what about their testicles? You think they might be small? Mm-hmm. Because testosterone's low, isn't it? So they may have a decreased sexual drive, and they may have a very sparse hair growth over their body. They may have, just like 3 little hairs on their chest, or, their pubic hair may be very sparse as well. So those are some of the things that we would also pull into our picture when we're assessing for erectile dysfunction. And we know to stay away from the nitroglycerins because why? Why do we want to stay away from nitroglycerins with the PDE?
And drop blood pressure.
Okay. And we want to avoid smoking, right? We want to avoid alcohol because those can interfere with the ability of the PDE drugs to work. And we don't need that if they're taking the medication. We want to do everything possible to make it be as effective as possible. What are some signs and symptoms of the TUR syndrome that you might be concerned about?
Decreased heart rate. It could be high blood pressure or low blood pressure.
Okay.
Confusion.
Their mental status. I'm sorry.
Seizures and coma.
Yes, seizures and coma, nausea, vomiting, and like I said, those can go along with so many other conditions. But the thing is that you recognize that this is not normal for my patient. What do I need to do to figure out what's wrong with him? Is it the low sodium, or maybe he's had a stroke during the operative procedure? So, there's a lot of things that we may not know at that point. Let's say that you have a person that comes into the emergency room that has a known history of BPH, and they've had a cold, and they've been taking anti or decongestants. What do you think might be a problem for them?
Does it interfere with the medicine that they're taking for BPH?
Well, actually, what happens is if they have BPH, they should not be taking any decongestants because it can inhibit their ability to void. So, and you'll see that happen occasionally. Little guy will come in and, I haven't been able to void in 12 hours and I'm so uncomfortable. And then you find out that he's been taking this decongestant for the last 3 days for his cold, but he didn't know. So that's something there again, we as educators and healthcare providers, that we need to make sure that the patients know if you have BPH, avoid taking any decongestants because it may very well inhibit your ability to void. What are some signs and symptoms of BPH?
Frequency.
Dribbling, okay. Yeah. Frequency, incontinence.
Weakened stream.
Weakened stream, yes. Okay. Let's say that you have a person, now we'll talk a little bit about urinary stones. Let's say that you have a person that has urinary tract infections pretty often. What's the most likely kind of stone that they have?
Trovite.
Right. Now, if your patient...
Can you repeat that? I didn't hear it.
If your patient has chronic urinary tract infections and they have stones, most likely the stone is the struvite, because remember, that's the one that is connected with the urinary tract infections. That's the only one that's connected most of the time with urinary tract infections. Okay. Now, let's say that we have a patient that has nephritis or glomerulonephritis, and we're giving them some medication to help with the reabsorption of protein. Do you have any idea which medication would be most helpful to do that?
cardiac or ACEs?
Lisinopril, because that's going to decrease the loss of protein. Okay. So that's the one of the ones that you're going to be very, you'll see used a lot with renal patients. Let's say that you have a person that has, let's say they have gallbladder disease and they come in and they say, I have not had a bowel movement in 5 days. What type of diet would be most beneficial to recommend for this person? Now, the diet's not going to help the issue at hand, but going forward, what kind of diet would you recommend for them?
High fiber.
What was that?
Low fat, high fiber.
Right. Yeah, we want to get that fiber in there because that's going to help absorb water, and water is going to promote the stool to flow through the GI tract easier. Now, if you have a problem, a patient that comes in with, they know they have kidney stones, maybe they've been treated for the last month for them, and they come in and tell you that they have not voided in 12 hours, why would you be concerned about that?
Blockage.
Yeah.
Okay, so what does a blockage cause?
Fluid retention.
Stagnant urine.
Okay, well, and remember, it damages the kidneys. If it is blocked and it flows backward up into the kidneys, it can damage them over time. So this is considered an emergent situation that needs to be addressed right away. So whether they need stents or whatever they need, it needs to be addressed so that we can preserve as much kidney function as possible. What types of food do we recommend for patients who have a known history of gallbladder disease?
What was the question?
What type of diet recommendations do we provide patients with known gallbladder disease?
Avoid high fat and greasy foods.
Yeah.
Okay. All right. We want to stick more with the baked foods, the foods that don't have a lot of fat and a lot of the concentrated carbohydrates in it. So let's say that you have a kid that comes in with gastric stenosis. What signs and symptoms are you going to be looking for if you suspect this with this child?
Projectile vomiting.
Okay.
Constipation.
Okay.
Failure to thrive.
Mm-hmm. Weight loss. And they're going to be hungry too. They may be cranky and grumpy because they're hungry, because we know how grumpy kids get whenever they're hungry. So that may be a problem.
Mucoid stools.
I'm sorry?
I was saying the mucoid stools.
Possibly. Especially if they have anything else going on in their intestines. What about your patient that has the strep throat? Let's say you have a kid that comes in that has had strep throat 2 weeks ago, and now they're presenting with weight loss, joint pain, pale skin. What are you going to suspect?
Glomerulonephritis.
Glomerulonephritis.
Right. Okay. So now if you have a person, a little, let's say a 4-week-old that comes in with gastric stenosis, how are you going to educate the parents? What type of signs and symptoms are you going to educate these parents on that they need to seek medical attention?
Lethargy.
Okay, what else?
Weight loss more than like 3% of their body or 5%.
Okay.
If they're not eating.
Yeah.
Okay. And if they're vomiting, they're having the projectile vomiting after they eat, any signs of dehydration, they may actually have some blood in their vomitus too, because they have gastric irritation going on in there, don't they? from the gastric stenosis. And they're going to be like your little cranky person, and because they're hungry and they just don't feel well. Now, let's talk a little bit about your screening for cancer. What does the three letters, the T, the N, and the M stand for?
Tumor nodes and metastasize.
Okay. So if you have a T2, an N2, and an M2, what does that mean?
H5.
Okay, what does it mean? What kind of tumor have we got?
What was the thing again?
I'm sorry, I didn't hear that.
Metastasized.
Okay, yes. It is a fairly large tumor. If you have lymph nodes involved, remember we talked about it depends on if you've got 3 lymph nodes or 15 lymph nodes that are positive whenever they're removed. That's what that little number beside the N means. That's how many lymph nodes are involved. Or if you only have 1, that's better. And then the M is the metastasis. Either it has metastasized or it hasn't metastasized. What is the benefit of having a PSA test done? Why do we even want to have one done?
It can detect the colon cancer or the prostate cancer.
Okay. All right. And it can be used to screen. Remember that this is a screening tool. It's not a definitive diagnosis. It's only a tool to help us determine if their level is elevated or not, and if they need a further workup. And, like we said, sometimes people have so many other comorbidities that something else is going to kill them before the prostate cancer does. What about ulcer perforation? What signs and symptoms of an ulcer perforation would you look for? What would you be alert for?
Increased abdominal pain and distension.
Okay.
Increased fever.
Okay.
I'll have like a board-like abdomen. It'll be hard.
Very firm, very rigid, very painful. What about vomiting? Do you think you would be concerned if they had bright red vomitus?
Mm-hmm.
Yeah, because that means they're losing blood from somewhere. And that can be a problem because it can lead to hypovolemia. And speaking of hypovolemia, what are some signs and symptoms of hypovolemia that you would monitor this patients for?
The increased heart rate.
Okay, good. You got to look at when a person is like, if they're hypovolemic, and that means that they're really dehydrated. What are you going to see in this patient? What are you going to be looking for? You're going to be looking for decreased urine output. Their heart rate may be up, and their cardiac output may be up initially, but it won't stay up. If they get to the point that they can no longer compensate, it will drop. Their blood pressure is going to be low. What does that do? I mean, it's just like a domino effect. It decreases the perfusion to the kidneys, so they could have some type of a kidney injury from hypoperfusion. Okay. Let's say that you have a person that has a colectomy for Crohn's disease. What is one of the complications associated with a colectomy?
You repeat the question?
What are complications that are associated with a colectomy from Crohn's disease? Okay, think about what you're doing. You're taking out part of the colon.
Would it be malnutrition?
Yes, malabsorption, malnutrition, because you're taking out part of the intestines, the colon, that the food would normally pass down. So there's nothing there to absorb it. So it's just going to go zip right on through, and they're gonna miss out on some of those nutrients that they would normally get.
Would there still be more? Would there still be more like of a liquid than a solid?
Depending on where the ostomy is. You remember we talked about if it's up higher, it's more liquidy.
Yeah.
And then if it's down lower, it's more solid. And it usually takes about 2 to 4 days for the ostomy to start working. If it's a little slow, sometimes we may give them a little bit of Reglan to push them along a little bit, because that increases the peristalsis in the intestines. So that sometimes we'll use that to kind of move them along a little bit and get their intestines to working much quicker than they would be normally. If you have a person that is experiencing the side effects, or what side effects would you expect a person to experience if they're taking the PDE5 drugs?
Erectile dysfunction.
Well, they're taking those drugs for erectile dysfunction.
Flushing.
Yes. The flushing, the nasal stuffiness, the headache, their ears are going to be red. So yeah, they're going to have all of those issues going on most of the time. Okay. What questions do you have for me?
What about Wilms tumors? What do we need to know about Wilms tumors? Is it just the side effects or signs and symptoms we want to see in the patient?
That was so limited. You just know what the side effect, what you're going to see in your patient. How's it going to present? You know, that they're going to have the mass in their abdomen. And then, of course, the treatments is usually either surgery or chemo or radiation.
I have a question. I've been practicing questions and like the peptic ulcer disease. In the book, it says that both of them, you have like that epigastric burning or pain at night. But in some of the questions that I practice, it says that only duodenal ulcers do.
Well, it can all depend. If they have esophageal irritation, they may have some of the, from reflux, they may have some of those feelings, those sensations.
So it's more common with duodenal than it is gastric, though.
Yeah. Okay. But now, and occasionally you will have somebody that has both. They have a gastric and a duodenal ulcer.
Yeah.
So, okay. Any other questions for me? Do you think this helped you?
Yes.
A lot of information. It really is.
I have a quick question.
Yes.
So both gastric and duodenal ulcers may or may not worsen with food, correct?
I didn't hear what you said.
Both gastric and duodenal ulcers may or may not worsen with food, correct?
Correct.
Because I've heard different things that one gets better with food and one is worse with food, but I just wanted to know what your take on was it.
It's very individual.
Okay.
It may or may not.
Make sure.
Mm-hmm. It's very individual, because what works with me, for me, what affects me may not affect you. So that's something that's very individual.
Dr. Buie, on the
the
peptic ulcer medications, like, do we need to know, like the antacids, like not to give like 1 to 2 hours between other meds and stuff like that?
Yes, you do know that. I don't have any questions related to that, but that is something that when you are practicing that you would definitely need to know. And remember, we talked about the caraphate, that you cannot crush it. You can dissolve it, but you cannot crush it.
Okay, thank you.
What else? Any other questions for me? Y'all are going to do fine on this Friday. I have no doubt y'all have been able to answer questions, and you've been attentive and everything. So I have no doubt you're going to do just fine. One thing that I do want to let you know, I will get your grades posted on Friday evening. It may not be right after the test, but I will get them posted on Friday evening for you. Okay. And I really won't be able to answer any questions until I have looked at it myself. So don't expect me to answer any questions like 2 minutes after you log off, because I'm not going to be able to do that until I look at it and look at the statistics and everything.
I had a question. The ED, the erectile dysfunction drugs, we just need to know the class. We don't need to know the med. Because the FOS5, there with the 3 different ones, I mean, depending on which one you take.
The PDE5, all of those are the main ones that you're going to use. And it's the sildenafil, the tadalafil, and what was the other one? It starts with an L, I think. So those are the ones the only ones that we're really gonna deal with, because that's what you're gonna see the most of right now.
Okay.
Does that make sense?
Yeah.
Okay.
So I just need to be able to differentiate those 3 drugs for the FOS5.
Yes. The sildenafil is a Viagra.
Yeah.
The vardenafil is a Levitra. That's the one I was trying to think of. And then the tadalafil is the Cialis. And remember, that's your recreation drug. That's your weekend drug.
Yeah.
Because it lasts a lot longer. You get more knowledge out of it. Okay.
Okay.
All right. Any other questions for me?
Thank you.
All right. Well, y'all have a good day. And let me know if you have any questions, and I will see you on Friday.
Okay, thank you.
You're welcome.
Thank you so much.